to another fun episode of Thrive Live. So today we have Dr. Freddy, who is an interventional preventative cardiologist. He has extensive training and experience, as well as board certification in internal medicine, cardiovascular medicine, and interventional cardiology. He has spent the last 15 years on the front line of care for ischemic heart disease, the #1 killer in the developed world. He has had the responsibility of stopping heart attacks in their tracks with placement of small metal tubes called stents. He is also the expert in utilizing technology to assess the hemodynamic flow rates through fluid models of blood flow, with a focus on the physiology of normal and pathologic mechanisms. So he can better develop strategies to improve blood flow throughout your body during your healthy times and during disease times. So welcome, Dr. Freddy. Now, Dr. Freddy and I kind of went right into chatting, and so I'm recording this intro separately. So enjoy the lecture. Let us know if you have any questions or concerns, and have a wonderful rest of the week. Bye. So you're in Florida this week, right?
I am. Yeah, I'm on the Gulf Coast near in Sarasota, and I'm doing another paper, and we just had our, I do the research here in Sarasota, and I was meeting with our FSU, Florida State grant writers and stuff, because we just took it. We started our first paper with zero calcium score and how epicardial fat volume is a risk marker. Then this is our episode 2 is with high calcium score, and we, it's 60 patients, but it's, these are people that have calcium scores, epicardial fat volume, and we're starting to show that maybe calcium score is really not the test to do. It may be the epicardial fat volume, because we had high calcium scores, normal epicardial fat volume, and the functional and structural cardiovascular issues weren't there. And then
interesting.
Yes, and we cast them, and if they had a normal epicardial fat volume, I mean, we didn't cast everybody. I cast a few of them. They had positive remodeling, so they didn't have obstructive coronary disease. It was in the paravascular or extravascular calcifications. It wasn't intravascular calcification. The signals, yeah. So it's almost ground. I think it's groundbreaking, but
yeah,
it's just something that, and we're gonna probably get into editorial debates with Budoff at UCLA and stuff, because he's a huge calcium score proponent. But the older cardio, I do all this research with this 84-year-old cardiologist. He's like genius, but he can't get the work done. He's got all these great ideas, but he just can't get it done. So that's where I come in. I get the students, and I review everything, and then we get the work done.
I love it. Yeah, you're just making me think. This whole time I've been promoting like calcium coronary artery scores is like, oh, all right, let's rethink that paradigm about how we view the cardiovascular system.
Yeah, exactly. And so our title is, he wanted to be very controversial about the title of the paper. He wrote, "Is it time to get rid of coronary calcium score?" And I was like, it's not time to get. I was like, he wants to, because he's 84 years old. He doesn't care what anybody thinks.
Right.
And he's super wealthy, and he's, but he's a great guy. He's Egyptian as well. And he's so funny too. He's such a family guy, but his energy level is ridiculous. And I was like, no, we can't. Let's not be controversial. Let's take the high road. Let's say, should we? I go, why don't we title it? Should we think beyond calcium score?
Yeah, let's just throw it out the bathwater.
yeah. I was like, let's just think beyond. Because everything right now is like beyond meat, beyond health. I said, let's beyond calcium score. And he goes, oh, I like that. And I was like, yeah, okay, let's do that then.
I like that. Wow, I can't wait to hear more about that research as you guys get farther into it.
Yeah, we're actually
Sounds like
submitting
you're
it.
far into it. Yeah.
Yeah, actually, I just reviewed, it's like we have two medical students these two women that are just third-year medical students are just, oh my God, they're on it. And they're like, we'll get you the draft this morning if you want to review it, and then we'll submit it. And I was like, okay. So I reviewed it. This is what I do. So I know what I need to look at. I just need to clean up some stuff. And I got it back to them, and they're like, we're submitting it to circulation, to AHA Circulation Journal. I was like, wow, already? Okay, all right. Because they put all the graphs together, and it's so amazing how, you know, we're kind of, you have the endpoint of cardiovascular disease, and I think it's too late. So that's why my endpoint is metabolic health, because here's the endpoint cardiovascular disease. I'm trying to get my hand, there you go. The endpoint for cardiovascular disease, it's too late. Here, metabolic health, that's my endpoint. And then you reverse, but you have to know the disease so you can reverse engineer back, and that's what we're doing.
I love it.
Yeah.
Let me actually just take a moment and back up, just
Yes.
because for the people who are listening who are not their brains not dive into cardiovascular disease. Take a moment to say that what's the number one symptom of cardiovascular disease? Heart attack?
Yeah, I'll tell you, a third of deaths of people above the age of 35 years old is literally sudden cardiac death. So the proportion is getting ridiculous, because some of these people's first presentation as a cardiovascular patient is sudden cardiac death. And that's a third over the age of 35. And then you add the angina and the heart attacks, which is every 42 seconds, I think. It's about 42 seconds or 40 seconds is, people are presenting with heart attack. And that's age 35 and up. And I mean, I'm the endpoint physician, because I'm an interventional cardiologist. So I'm the guy that gets called at 2 o'clock in the morning. And so I have to stop what I'm doing. And I've noticed in the last couple of years, the age has been getting younger and younger and younger. And Jenny, I was telling you, I pulled 40 of my last, they're called STEMIs. Those are heart attacks. That's where you clutch your chest, or you're short of breath, or you're so sweaty and you feel like you're going to faint. And you call 911, and if that's a four alarm fire where everything stops and we have to come in emergently. And I pulled my last 40 of those, and I found age clusters from 30 to 50 years old. And these were young professionals, high stress, no sleep, poor nutritional choices. And we figured that out after the fact. 39 out of the 40 survived. The one that didn't survive was a 52-year-old having a peach at the bar with his family. He's at his bar in his house, eating a peach, falls back dead. And so when you think about it, I said he was with his family. He's only 50. So his twin boys were in their teens. So when you have these types of situations, it's not just the patient; it affects their entire family. And he was a prominent interior designer in my area, and he was well known. And knowing that I was on the case, I did everything I could for him, and his brain just didn't wake up. And that's what happens. And he was perfectly fine the day before, the hour before. And that's where the unpredictability of cardiovascular disease is. It's even the Las Vegas hedge bettors can't bet against this. They don't know how to give you the odds. When you say it's going to happen every 42 seconds, okay, that's fine, but you don't know who until now, because we have some ideas of who are going to be those patients. And unfortunately, 88% of Americans are metabolically unhealthy.
Oh yeah, 100%. And let's talk about, well, a couple of things. Yeah, because I'm getting more and more unfortunate 35-year-old range in my practice, post MIs, post heart attacks. And it's just like, whoa, you're 35 and you just had a heart attack. And, what are we looking at? Exactly what you talked about: diet, lack of sleep, stress, those foundations, plethora and genetics on top of it. Um,
Yeah, the genetics has it plays a role, but it's amazing how small a role it plays when it comes to, it's about 20-30%. And when it comes to lifestyle choices, like the things I call it my NEST program. NEST is an acronym for nutrition, exercise, sleep, hygiene, and tackling stress. That from all the stuff that I've been doing for the last 15 years, and then finding the end point, which is finally having your heart attack. And remember, I deal with patients that have strokes as well. I deal with patients that have high blood pressure, high cholesterol. I deal with a lot of heterozygous, meaning you're a carrier for familial hypercholesterolemia. I deal with homozygous carriers. And those people, are 20 years old that I place on PCSK9 inhibitor injections in addition to high dose statin, in addition to plasmapheresis, because we know this is what I do, because I run a cardiometabolic clinic. This is what I do on a weekly basis. So when I hear a lot of controversies about the lipid hypothesis, the LDL hypothesis, what I always think of when I hear that is that when people say that, they're actually thinking about it in a vacuum as a one component thing. And when you're a homozygous carrier, meaning you have both genetic polymorphisms for familial hypercholesterolemia, that's kind of the gold standard of how LDL and atherogenic lipoproteins affect the cardiovascular system. And that's what really caught my interest. And I'm actually trying to recruit homozygous familial hypercholesterolemic patients and their families to check their epicardial fat volumes.
Got a couple of patients. I'll have to see if they're homozygous or not. But yeah, as you're going down that list, I'm like, oh yeah, check out these couple patients that I got. Yep.
Yes, because in our most recent paper, like I was telling you earlier, we're trying to find, what we're trying to do is we're trying to find objective early risk markers as opposed to a risk factor. A risk factor is like you have your high blood pressure, or you're insulin resistant or carbohydrate intolerant, or you have your triglycerides are a little high, your LDL is a little high, you maybe have a little waistline. That's all metabolic health, and those are risk factors. A risk marker shows that you already have signs of some sort of disease. So, and what I've learned, that when you're able to educate people and give them that tangible diagnosis, it has teeth. And now evoking behavioral changes is actually going to be, you'll have more success. And I always think of it like when people get that, God forbid, cancer diagnosis, a lot of them don't realize that they have tons of nutritional deficiencies. They don't even realize that their papillary thyroid probably could have been prevented if they had adequate iodine and biotin, right? I mean, that's your specialty, Jenny, and it's amazing how, or touching that fire receipts with those hormone disruptors, what all those things do, or lack of iodine, lack of essential B vitamins, the B2 all the way to 12, and how those, when you don't have those appropriate nutritional complementary additives to your natural foods, it actually sends signals. Because a lot of these cells have independent mRNA signals, as like epicardial fat has an independent mRNA signal, so it will replicate accordingly, independent of any other organ in the body. And so what happens is then you get a mismatch in your anti-inflammatory and your inflammatory response. And most of them, if you have these deficiencies, you have a hyper-inflammatory response. And that's what we saw with excess epicardial fat. You have an upregulation of mRNA. The fat increases around the atrioventricular groove of the heart. It's the part that separates the upper and lower chambers. And all of a sudden, the adipokine homeostatic balance is tipped for the inflammatory response because, and you have the upregulation of, and you know these IL-6, IL-1, TNF alpha, the same markers that all the cancers love. And when you have high processed carb diets, you don't sleep well, you have stress that's not managed, and you have upregulation of all of those hyperinflammatory markers.
That also just makes me think, because I do a lot of the postpartum phase, and postpartum, we see a massive upregulation and all those inflammatory markers, particularly through the chynogenic pathway. And we also know that, pregnancy, you have that massive spike in cholesterol. And I wonder if like that pregnancy postpartum phase, this also makes sense in terms of, what, maybe that's a huge risk factor for, women, moms in their cardiovascular disease risk, especially if like their gut wasn't good, nutrients weren't there prior, all those foundational layers.
Oh yeah. And in pregnancy, I see so many pre-diabetes, and we do tons of oral glucose tolerance tests, but I've been checking a lot of fats and insulins as well. And it's funny, and then you have the hypertensives in pregnancy as well, which is the prevalence is going off the chart. And I think you got to take the approach that the government intervened. I think it was like 1995 with the folate supplementation, when they made it mandatory that you have folate supplementation fortification for pregnant women to decrease the neuro-2 defects. And I'm thinking that something like that has to either as a grassroots with respected naturopathic, homeopathic, allopathic docs that think a little more globally, like a homeopathic doctor such as yourself. Allopathic, some people may not know the difference, but allopathic is I'm an MD, we prescribe medicines that have the opposite effect than the disease. That's literally what we do. And homeopathic, like you actually look at the root cause and try to adjust it through a more natural, holistic approach, which is the right approach. And that's why I'm still in the allopathic world, but it's so important to bring this lifestyle, metabolic health through the frontal cortex, so we can start tackling it, because 88% of the population this is from research in 2019, is metabolically unhealthy. It's probably 98% now after all this quarantine. But young Yale students, research a couple years ago, 40% of these 20-year-olds who had zero risk factors, normal BMI, normal waist, normal blood pressure, didn't smoke, didn't drink, well, maybe drink on weekends, but 40% of them were already insulin resistant. And you kind of wonder, why do we have an obesity, overweight epidemic? Why do we have a cancer epidemic? Why do we have this COVID epidemic and pandemic? And it's because the foods we choose, the sedentary lifestyles we choose, it's all lifestyle choices. And so that's why I'm hoping, if I can give you teeth of this subjective marker that you're like, whoa, and it's like getting a cancer diagnosis.
Yeah.
A lot of cancer patients, they're told that they have to go on this chemo regimen that literally kills them, and most do it. They're like, yeah, sign me up. Or you have to have surgery to cut it out. Most do it. They don't even think twice. And that's how we need to get this cardiovascular metabolic health. That's how we have to get people to start thinking, is to be aggressive about it, because man, I'm telling you, 42 seconds, chronic disease.
It's scary.
It's crazy.
It's scary. Crazy. And that's when we even think about the risk factors, the type 1 diabetes, the hypertension. In my opinion, those are already late stage. Right? We should have been addressing this before it happened. Your body throwing with that billboard. And by the way, nice Oura ring. I saw you waving it around.
Yeah.
Yeah. And yeah, that's where, but patients and listeners, I'm trying to get that message across of like, okay, so you have high blood pressure. Silver lining is let's figure out why you have it and address it and fix it. Let's just not, I'm a big believer, time and place for everything, and a blender of allopathic and naturopathic and homeopathic meds. But let's be very conscious about how we're using things so that we know we're still getting to the root while we're keeping them safe.
Yeah, it's, it's from doing what we do now. I always try to come from an angle of high principle, from not only how you carry yourself, but what you put inside your body in terms of nutrition, what you feed your mind. Like, are you watching TV? Are you spending time with family? Are you out in nature? And those are high principle moves. If you think about that for a second, okay, I'm going to spend time with family. I'm going to look to keep the environment clean. I'm gonna look to support my local farmers market, from table to farm to table to whole food consumable products. And I think if you come from that angle, then things kind of fall into place. And that's the approach I've really started to take in the last couple of years. So far as I even enrolled in a integrative fellowship. I mean, I went to med school in Boston. I went to college in San Diego. I'm from San Diego. I went to UCSD, studied biology and music. So I was a music minor, biology major. Then I went to business school because I was interested in healthcare finance, then med school, and then another 7 years of training in medicine and cardiology and interventional cardiology. And now I decided to matriculate into an integrative health and medicine fellowship. So, I mean, so that when I think about that and I reflect on that, it tells me because there's something in there that's very important. And I find that integrative approach is the only approach.
Yeah.
The reactive medical model that I've been in for 20 years doesn't work. It worked for emergencies, like if you have a appendix or a gallbladder that needs to come out, or you have a stroke, or you have a heart attack, or a AAA, or a trauma. The medicine, the system that I'm in is perfect for that, and you need it. But the bulk of people on a daily basis don't need that. And so what people need on a daily basis, it's like anything, right, Jenny? To do your job every day, you're reading stuff, you're interacting, you're going to the office or not, or you're seeing people every day for about 5-6 hours a day, maybe longer if you put all the time together. And that's exactly what you have to do when you're trying to optimize understand what total well-being and health is. That's what you have to do. It's the same principle. You have to put in the 10,000 hours. And that's really where I really started to take the knowledge, because I've seen too much death. I mean, I would come, my kids will hear when I have to leave, like at 1 o'clock in the morning to go to the hospital emergently. The next morning, I always keep a game face on. I never act tired. I never complain about the job, because that was that patient's probably worst, if they survived, that was their worst moment in their life. So what am I going to complain about? So, that's how I look at it, because you can feed your mind. You got to be the positive. It doesn't have to always be positive, but when people are in those vulnerable moments, they need strength and positivity, and that's what we deliver. But it can't do it one time a year for 5 minutes. And I'll tell you, the average medical practice interactions is 2 to 3 minutes once a year.
Yeah.
That's the
what
medical.
What are you supposed to do in that time?
Well, in the model, half the time
Right.
you're documenting. And so, I mean, the group, I was with a single specialty group for years, and I would see 20 to 30 patients a day, sometimes more. But I would also operate half the day. I would operate maybe 5 to 10 cases the other half of the day, and I would do like TEEs and echoes, and really, I'm such a procedural based cardiologist, because that's what pays the bills. But really, that's not what the community and population needs at all. It's not, you know.
So speaking of going to the next step on that, so what would you say are the most important three things that we can do for cardiovascular disease preventative?
Oh, I mean, I think these are probably three for any kind of chronic disease, and cardiovascular happens to be the number one killer. But the first now is sleep. My acronym is NEST. I start with nutrition, but starting with the S it doesn't sound good. It sounds like net. That doesn't sound good. So I went with, but sleep, knowing what I know and what I've researched and looked through, and I have a good friend who's a sleep apnea specialist, sleep specialist. Sleep is number one because if you don't get enough sleep, 7 to 9 hours of good restorative non-REM and REM sleep, you're in sympathetic, you're in fight or flight, and your lipoprotein lipase is activated, your adipokines are activated, your inflammokines, your metabolomics are off, your proteomics are off, and that all starts with sleep. And that's before any kind of nutritional insult or exercise or lack of exercise insult. It all starts with that circadian rhythm that you develop by good sleep. And it's interesting, a fact that I just recently learned, and I'm constantly learning. I'm such a humble servant to education. I never and ever act like I know more than anyone else. I never do, because someone else always has something to teach. And I picked this up the other day, that if you don't get good REM sleep, the dream phase where your eyes are going all over the place, then your brain cannot heal itself from the traumas or emotional distraught from the day or two before. So, and if you drink a lot of alcohol, alcohol keeps you out of REM. So you don't allow yourself to brush off the stuff from the day before. And I thought, oh my God, that's incredible. I never, so of course I look it up, just and then I don't trust what anybody says. So I looked it up, and they were right on. I shouldn't question a sleep specialist, but I did, but not face to face. But that's, and so that leads me down the rabbit hole of restorative sleep.
Yep.
Restorative sleep allows your brain to expunge all the byproducts of metabolism, keeps the proteins from maintaining their three-dimensional configurations through FOXO and all that stuff. And it helps your body's muscles repair themselves. I mean, so it all starts with sleep, and you really need to keep a sleep journal if you don't feel like you're having, and then make sure you don't have any organic medical issues that are like thyroid or mental or alcohol issues or hormonal issues.
Mm-hmm.
And then number two, then it's nutrition, because like, again, it's high principle. It's what you put into your body, what you put into your mind. And I'm a proponent of a primarily plant-based. I'm not tribal about it, but I do not promote the high extremes. People go vegan for humanitarian and other issues, which are debatable, first of all. Anything in extreme is always debatable. And then you have folks that are on the carnivore, like all you do is eat meat. I remember the Neanderthal were all meat, and they went extinct. They didn't survive because they didn't have the metabolic flexibility. And so there's always moderation somewhere in between. And then it's keep moving. Number three is you gotta move, low level movement every day, all day, like that. So I never sit down when I'm at my desk. I stand, and that's called exercising your non-exercise activity thermogenesis. And that's where you burn more calories a day than traditional exercise. If you did the traditional 30 minutes a day for 7 days, you'll meet, the recommendations are 150 minutes per week of moderate intense exercise like brisk walk or what have you. But if you did 30 minutes a day, that's going to burn probably 200 calories. That's it. But your non-exercise activity thermogenesis, you can burn up to 2,100 calories. And that's the concepts of your 10,000 steps, take the stairs, stand when you're at your desk. That's where those concepts come from. No one really, and there was actually a really good trial. It was around above 8,000 steps. There was a mortality benefit, meaning lower chance of death if you moved about 8,000, at least 8,000 steps a day. And the old hunter-gatherers from past who ate a wide variety of nutritional choices and slept very well with the sun and the moon, they logged 50,000 steps a day, 50 to 80,000 steps a day. But they, they died of infections and stuff that we don't die from now. And so those are, I think, the three really key pillars for optimal wellness. And that will cover cardiovascular, that will cover diabetes, that will cover cancer, that will cover diabetes type 3, which people call Alzheimer's now, that will cover your response to viral infections. It covers the gamut.
Autoimmune disease, yeah. I mean, everything you're saying.
Autoimmune disease, yeah.
Yeah, yeah, because it's, I mean, and going back to that, sleep is so important, because if you're missing your growth hormone phase, your release, or you're missing the restructuring of the neurofibrillary tangles in the brain, or that's when your body heals at night. And if we are literally skipping that, we're just in a catabolic state the entire day.
Oh yeah, I mean, everyone now hears about heart rate variability measures. I use a Garmin and an Oura ring.
Oura ring.
Yes. My wife was saying, "Oh, I want you," because I never wear jewelry. And she's like, "I want you to start wearing a wedding ring." I was like, "Okay." And I was like, "Oh, let me get the Oura ring." She's like, "Oh, I picked out a ring for you." And that ring was like $3,000. Like, no way. An Oura ring was like 300. I was like, wow, it's a win-win.
You nerd out with all the biometrics coming out of it too.
Yeah. And so I'm such a biometric wearable tech geek. And I've been following heart rate variability my entire career, because that's what cardiologists do. When we order your Holter monitor or your event monitor, you have to wear those 3 stickers for like 48 hours or for a week or 30 days. We are actually looking at your heart rate, not just your heart rate, but we actually look at your heart rate variability, meaning the distance, the fluctuations between each beat. And the more fluctuations you have means the more flexible your system is to stress. And are you inflexible to handling that stress? Because we see a lot of trigger-mediated atrial fibrillation. And that's what brings me back to epicardial fat volume again. We know higher fat volume, higher obesity, higher rates of atrial fibrillation, higher rates of sleep apnea. So it all comes together, and we can pick that up with looking at your heart rate variability of your sympathetic drive versus your parasympathetic drive. And that's why the gurus and influencers, there's a ton of people out there on teaching you how to breathe, because that controls your parasympathetic, gets parasympathetic back into control. And believe it or not, it's not that hard. The gurus are making it too difficult. There's not 50,000, there's not, just breathe.
Yeah, I love it, because I literally explained this, I don't know, 10 patients.
Right, Jenny? Just breathe.
The vagus nerve right into the middle of the chest, innervate the heart. We're going to put some pressure on it with your lungs. Massage that nerve down.
I've seen, because I've befriended this really interesting guy on Instagram. He's super cool. He works for the Art of Living, and he has a guru, Sri, and he is so, you would love, maybe you can have him on an interview or something, because he's so peaceful. And he says, no, don't worry about the breathing. Just be aware of your breath. That's the way to start. And then you can get complicated if you want. Just be aware of in and out. And that's really what you can do. Or just close your mouth.
Yeah, I just took a deep breath.
Close your mouth. Yeah. And shake it off. And
I love it. So how do you suggest testing the pericardial fat, sorry.
Yeah, no, epicardial. It's interesting, because epicardial fat and pericardial fat are very different. The pericardial is, between the chest wall, and it's
Yeah.
separated by the pericardial space. The epicardial fat, literally, it's not separated by a fascial space. So it literally sits on the heart, and it actually shares the same blood supply as the cardiac muscle. And it actually has mechanistic, thermogenic properties, eccrine and paracrine properties, meaning hormonal, like adiponectin, adrenomedullin. And when you get excessive epicardial fat, you start to get upregulation of resistin and leptin, which are not good, because an
Right.
appropriate adiponectin response, which is only secreted by adipocytes, those usually, with a normal epicardial fat volume, you have anti-thrombotic, anti-diabetogenic, anti-obesogenic, anti-inflammatory properties. And once you gain weight, or you start to notice, just look down. Whoever's listening, just look down at your belly. If your waistline is 1 or 2 inches more than when you're at your thinnest, you're probably insulin resistant, and your epicardial fat volume is probably growing. And we know that because waistline correlates very well. It's called the R correlation, or coefficient of R1 equals, it's 1 to 1. It's about 0.8, 0.9, so close to 1. Waistline measurement, or sagittal abdominal diameter, correlates very well to total body fat as well as visceral fat. And so that epicardial fat is it's a normal process. It's a normal functioning endocrine organ when it's at normal levels, usually less than 90 cubic centimeters. And once you start to eat the high processed foods, or you get into energy surplus, because there's empty, nutrient poor calories literally at every corner. McDonald's,
Oh, yeah.
Whole Foods,
Starbucks.
groceries, Starbucks, yeah, nutrient poor calories, and you get energy surplus. You overwhelm mitochondrial oxidation of for energy making, driving glucose into cells to form glycogen, and then you get a problem at glucose transport. It's actually, I think, GLUT4. And then you develop insulin resistance. And once you develop insulin resistance, the liver kicks in, because it sees 3-4 times insulin levels than what your periphery sees. And so that drives lipolysis, that drives then drives adipocyte hyperplasia and hypertrophy. And it's the hypertrophy, that theory, that drives the metabolic syndrome, the insulin resistance and metabolic syndrome. And epicardial fat is kind of like the driving force when it starts to get larger, because it's not ectopic. Visceral fat is ectopic.
Yeah.
It's not ectopic. It's just growing, and it has a hormone responses independent of the rest of the fat depots. And the wonderful thing that we found is there's the allopathic method of treatment, high dose GLP-1 agonists, like those diabetes drugs that you hear about that people are using for weight loss now, or SGLT2 inhibitors. That's the allopathic way that can drive, and statins drive the epicardial fat down. But I prefer the lifestyle. We noted that everyday exercise with occasional high intensity will shrink that epicardial fat, like it does preferentially shrink visceral fat before subcutaneous fat, the high intensity training. So you can literally turn this all around with lifestyle choice. And that's my point. And then you have to get involved with either Dr. Abercrombie or myself, so we keep you accountable through an aligned health model. Like I was telling you before, 10,000 hours, where when you do something and you do something well, you're doing it every day for several hours a day. And that's the point. That's why this whole new medical model has to change.
Yep. Totally.
That answer your question?
No, I loved it. And I never even really thought, you're just changing my perspective. I've never really quite thought of the epicardial fat as like its own organ system, basically, right?
Oh.
It's functioning as its own organ system. I didn't even think about that.
And I'll tell you, it's, I can even take it just a little bit further down on the anatomic and atomic scale. when you have that imbalance in adiponectin and adrenomedullin, now adrenomedullin is the force that drives the nitric oxide synthase, because heart primary source of energy is free fatty acids. So when you have free fatty acids, guess what you make? You make a lot of reactive oxygen species. So adrenomedullin, you have to create an antioxidant environment, and that's what adrenomedullin does. And what we find when you continuously insult your system, the body's amazing. It will repair itself for years. You'll be insulin resistant. This is the scary part. You'll be insulin resistant for years and not even know it. But if you keep insulting the body, you're going to overwhelm your mitochondria. That's where it starts. The uncoupling protein disappears through complex 1 and 2. And now it can no longer efficiently make ATP utilizing oxygen. Now you get a state of inflammation. That's what drives, that's when you get to the state of inflammation, is when you develop diabetes. Because when you're insulin resistant, you're still normal sugars in the blood. Isn't that amazing? Your usual basic laboratories from your primary care doctor are all going to be normal.
Yeah, because your body's going to want to keep those electrolytes so in check, the glucose so in check. So by the time they finally come out of range, we are like way beyond where we should have been.
We are so behind the ball, and that's why we need to take measures that enhance the vascular age. And at that endothelium, there's a gel-like substance called the endothelial glycocalyx. My theory is, and I'm hoping we can prove this. Fortunately, we need samples, so it's going to be post-mortem samples. And I'm working with a guy at Florida State who has post-mortem samples for arrhythmogenic heart disease. So we can look at what their epicardial fat volumes are, because a lot of those folks had CAT scans. We can go in and calculate it. It's very simple. It's an algorithm using Hounsfield units, because fat has a certain Hounsfield unit, and it's the fat that's in the atrioventricular groove and on the free right ventricular wall. Very simple. Very easy to do now because the CAT scans are so easy at low radiation. And so what I want to do is, my theory is the high epicardial fat volume and the high inflammatory markers break down that endothelial glycocalyx, and that's what erupts the inflammatory response to try to repair it. But it's too late, because you have so many atherogenic lipoproteins that have already activated the leukocytes or foam cell formation, and that's kind of my theory of how this all happens.
Yeah. Well, that's why I know all the antioxidants can help the endothelial dysfunction on that.
Yeah, and what's unbelievable is, if you look at, there's a lot of epigenetic evaluations, a lot of epigenetic companies and a lot of genetic companies out there right now that are trying to get to the core SNP or polymorphism, and a lot of it bases off of familial hypercholesterolemia, or a lot of the arrhythmogenic heart problems, or hypertrophic cardiomyopathy. They all have these genetic spikes. And what's interesting is, if you look at a lot of the treatments, for example, you've heard of the MTHFR gene and its polymorphism and homocysteine poor utilization. Aside from folate supplementation, a lot of the treatments are Mediterranean diet lifestyle.
Yep. Yep.
It's so simple. It's so simple, and that will cure a lot of these issues, and a lot of young families won't be completely turned upside down because dad or mom had a heart attack in their 30s. And let me tell you, I had so many patients, 5-10 years later, they still haven't recovered financially from it. Yeah. I mean, it's a disaster.
It is a disaster. And going back to the epigenetic piece, that also goes back to your foundations of sleep, diet, exercise, because those all improve how those genetics function. And it just goes back to these foundational layers that end up improving our mitochondria, our Krebs cycles, our our interior biochemistry and genetics. And it's, to
And
me, it gets so exciting because there's such foundational things that are simple that work.
yeah, oh yeah. And so I'm on I was just asked to be on an advisory board for one of the genetic companies, because we have a database, and I'm also so clinically oriented, and not afraid to spend the time with clients or health participants, that we are going to check, you know, the genetics of all these cases that we have, the ones that we're following the epicardial fat volume, because we have all their metrics, from their inflammatory laboratories to their BMI, weight circumference, to the usual basic labs. In addition, we check their endothelial function using, it's called C1, C2, large vessel, small vessel. We do retinography, where you can get actually a clear bird's eye view of what the artery actually looks like. You can see, remember Hollenhorst plaques? Remember all that?
Oh
You
yeah,
can see,
and it's like thinking
yeah.
back to med school. I'm like, oh yeah, I remember
Oh,
all
yeah.
that. You literally see what the arteries are doing inside your body through your eyes.
Oh, yes. And we
Yeah,
do retinography. We will take a picture of your eye, and I can tell you your blood pressure is too high for you. Well, no, my doctor says my blood pressure is 130/80 once a year. I was like, no, your blood pressure is very different because of what your eye looks like. And then we put a blood pressure monitor on for a week, and sure enough, their blood pressures are 140, 150, because they're not sleeping well.
yeah,
And then we check glucose monitors. I'm testing out NutriSense right now, to give my input, and I love it. I'm afraid to say that my blood sugar is a little higher than I thought it should be.
yeah.
And I look, because I love sushi, so I'm going to change that. Now that I know, I'm going to change that. I'm going to eat sashimi.
Yeah, feeling great. Yeah, I've been wanting to get a continuous glucose monitor for patients, just as extra data to know, like, okay, look at what happened to your blood sugar levels when you had that stressful meeting at work, or you didn't sleep, or you decided to skip breakfast and you had that coffee. Let's
Yeah,
give you those
that's
feedbacks.
that's what I noticed, because I'm doing a test. Yeah, I'm human. I mean, I like to have a bourbon every once in a while. I like to have a beer. My best friend's a beer, one of the largest beer distributors in California. And so I'm doing a test. I have one drink a night, around 6 o'clock, because I'm seeing what my sugar does. I I usually don't eat breakfast because I'm never hungry. But I do have a coffee with turmeric in it and black pepper, cumin pepper. It's really good. Um, and I noticed that when I have that coffee with that combo, my blood sugars go down. But with the one alcohol drink, that's probably why, I think, because alcohol is a sugar,
Yeah,
and your insulin goes like this. So next week I'm actually covering the hospital, so I won't drink at all, but I'm going to maintain the same dietary principles to see what my sugar does. And really, that's how you empower your health participant. And I like to call it an aligned health model, a proactive health model. And that's kind of what we do in practice now. I'll actually check your calcium score, even though, it's not as useful
the old
anymore
bathwater. Yeah,
from my point of view, but we do it anyway, because I do a coronary angiogram with it, a CT angiogram. So I'll look at your arteries, as well as your epicardial fat analysis. We look at all your vascular analysis, and depending on what people are willing, how far they're willing to go. Because if someone is just like, I want to do everything I can to know what I can know, so I can do what I can do. So that's the first, is how much do you want to know, in order to, or some people say, I don't really need all that, but I'm very coachable and I will do what you say. Okay, that's not, most people aren't that, in my experience. So we call it our premier program, where we will actually put you in the CAT scanner. We even have an MRI if people are nervous about the CAT scanner. We can do MRI, and then we do the whole, we'll actually look at it all. And then we have such a, we have a couple lab packages that are, most doctors haven't even heard of the stuff that we're checking. But we also now, because I love the genetics, and because I work with FSU, and we have this really amazing PhD researchers that's all into it. Now we're adding a genetics package. And so obviously I researched all the high yield genetics that we check. And the beauty of it is, genetics play about 20-30% role. And that's where epigenetics comes into play, and that you can turn things on and off. And so we don't, and let me tell you, we don't mess around, because I tell anyone who wants to work with our team, I tell them, you're going to be active in this. You are not a silent player like you've been for the last 10-20 years with your previous doctors. No, you're going to get texts from our nutritionist. You're going to get check-ins, because you're going to have a goal every week, and you're going to have a little win each day so you hit that goal. And you're going to do that over and over and over until it becomes a habit. And until it becomes a habit, we're still going to bother you. And our goal is to kind of leave you out into the real world on your own. And what's interesting is when we do that, they always come back. Because it's interesting, and it's like, we actually empower these people. And that's why I need to get to them when they're younger. We got to get to them when they're younger.
Yep. Let's get people's heads out of the sand. Let's talk about mental health, cardiovascular disease, autoimmune disease, Alzheimer's, dementia in pregnancy. Let's start at conception or before conception, right?
Yeah. It's so important. So important. And being that, I've seen so much death that in going back to the story I was telling you with my kids, when they would hear me leave like at 1 a.m, because I got to open up the garage, and I drive a Jeep, so it's kind of loud. And then my neighbors, then the next day, everyone, oh, did you have to go in the morning? I'm like, yeah. And they all ask, did they survive? My kids, like, seriously, did they survive? And I'd be like, yeah. So 9 times out of 10, I say yes. And that one time I say no, oh man, it gets harder too as I get older.
Yeah.
I start thinking about the families. I start thinking about their kids. I start thinking about the bills they're going to have. And I'm just like, oh, these poor people. And so that's why we gotta make the paradigm shift. The paradigm shift is yesterday.
Yes, exactly. Yep. And it's, just look at the finances of having to recover from the hospital bills of a heart attack. And then what if you just invested that money to not get the heart attack in the first place, and then you invested the money to not have that stress and burden on the family, and worth every penny.
Yes. The average cost per year for one patient who has a heart attack per year is around $30,000, and per person, about 30, and that's lowballing it, because that doesn't account for job loss, and so that's the hard number of what's going to cost per year if you have a heart attack. So now you're going to tack on all the medicines, because I'll tell you, each person that comes out after I treat them, they're going to be on five different medicines, high dose. And then a lot of their continuity is going to be driven by their insurance company, who don't care about them at all. Don't care. They're just a number. It's a hedge fund for the insurance company. And so the cost burden, so when you look at that cost on an individual basis, and a heart failure is around 25,000, 30,000 per year. And once you have the heart attack, that's 25,000. Now you develop heart failure, it's another 25,000 per year. And then you look at, well, doc, how much does it cost to work with you? And I was like, well, I mean, if you don't listen to what we're saying, and you don't have an idea of what the value is, then you probably weren't listening. It's high quality, and preventing death is priceless. It's a priceless thing. And that's what we're talking about. It's strategies to arm each individual to delay, if not prevent, the number one killer from getting them. Yep. And the strategies have been proven over and over and over. And they're so simple. You just need accountability and close follow-up.
Accountability. Yep.
Mhm.
How to develop those lifestyle and habits, because that's actually what takes all of the good work that you do and projects it forward so that you maintain all of that moving forward. 100%.
You got to put in the 10,000 hours. That's why a professional. So Jenny, if you, Dr. Abercrombie, if you look at the hours spent when you got your doctorate degree, it was about 10,000 hours. A pilot license is about 10,000 hours. A physician, an MD, same for med school, so it's about 10,000 hours. That's what it takes to be able to make it a habit of learning, staying
Yep.
on top of things, and trying to be the best you can be. And
Yep.
makes sense.
It does. And then you feel good. You got energy. You don't have brain fog. You can go out and hike and keep up with your kids, your grandkids. Um,
Look at me. I'm 48 years old.
you're like,
I'm Yeah, I'm 48 and I surf, I windsurf, I cycle. That was signed by Greg LeMond. I cycled with him in Boston. Um, and and most of my peers, my cardiology peers, are twice my size. And after a while, they make fun of me at first. Oh, you're a preventative this and this, that. Then after a while, they'll come up to me, behind closed doors. Hey, how are you? How do you stay so fit? How do you? And I said, well, it's not how do I do it? It's just I chose a lifestyle that I like to windsurf and surf and stand up paddle, cycle, and I don't want to get hurt. I like to snowboard, and I don't want to get hurt. So I train and eat with high principle and high integrity. That you have to put the work in, and you have to put in good nutritious food to your body, good nutritious news and education to your mind, and in order to prevent injury and remain flexible and strong and stuff. And everything else, the brain fog goes away. Testosterone levels are normal. Even my even my FSH or estrogen levels are normal at my age, and my cholesterol was a little elevated, but that's because my HDL was so high. But my ApoB is we're literally in the 20. I don't take any medications. And I always check my blood pressure. I wear wearables. I make sure, and if I start to see patterns, that's what's great about wearables. It's not perfect, but you see patterns. Now I know, yeah, now I know I'm human too. I love pizza. So I know if I'm gonna eat pizza, I'm gonna eat a couple pieces. And for the next day or two, I know I'm gonna be pretty much vegan.
yeah,
That's I'm gonna eat only broccoli and and tofu and soy products, and I'm gonna make sure when I go out to windsurf, I'm gonna make sure that I punish myself, because that's the balance. Because I
yeah,
just literally healed my body probably about a year by eating a couple pieces of pizza. So I got to get that back, and you can get it back.
yeah,
You
yeah.
don't kill yourself. You don't get hit by a car.
Right. Yeah. Yeah. It was my husband's birthday earlier this week, and I was happened to wear my Aura ring during the week, and then
Yeah.
so we had this delicious, 100% dairy ice cream cake from the best,
Yeah.
uh, you know,
Corbell.
ice cream place in Colorado Springs, delicious. And I just watched my stats from sleep that night. Like my heart rate variability just blew up. My resting heart rate just worse. And I was like, all like the red flags on my Aura app were like sleep quality, your heart
Oh
rate.
yeah. It's amazing how
Yeah.
I had a rough call 2 weeks ago. I had to come in emergently for a 58-year-old guy out of hospital cardiac arrest, died at home, family's doing CPR on him. And I literally and then when I was done, I had to jump on a plane. And so I literally got 1 hour and 22 minutes of sleep. And my aura was like, my heart rate variability was in the toilet. My aura was like, what? You know how it says, wow, you really did well. Mine said, WTF. And like, and I put it on social media, and I was just kind of testing my followers if they've been kind of following along. And I asked, I said, what do you guys think I should do? And it was amazing how a lot of my followers said, dude, your Nest program, right? And so you're going to watch what you eat, you're going to hydrate well, you're probably going to exercise and probably go in cold water and do some sauna work. And I was like, yeah, that's exactly what I'm going to do. I'm going to take, I don't take a multivitamin, but I did, because I eat so well-rounded. I have a little iodine here, a little bit, I have all the stuff that I need for my lifestyle. And I was impressed that a lot of my followers knew exactly what I was going to do. And I was like, all right, okay, cool. I was so happy. Yeah, it was cool.
So not to cut it short, but I got to move on from a patient. Right after an
That was an
inpatient.
hour. No, we're good. Yeah,
Yeah,
the kids are about to, the
bust
neighbors
through.
are getting restless.
I love it. Well, I will post your website and social media handles at the end of this. Everyone, if you want to connect with Dr. Freddy, he works within the same frame, like aligned health program type style that I do as well. And so I'll have all of his information there so you can connect with Dr. Freddy.
Jenny, thank you very much. I really enjoyed this. Thank you for having me.
This was super fun. Thank you so much. And continue all of your awesome work that you're doing.
Keep in touch.
All right. Bye.
Peace.